Hello. So last year I stood up here on my, third day of work, I think it was, at ALS TDI, and I compared the work that we're doing, this Stardust model that we use to evaluate the data in the ARC study with a crime scene, taking a forensic crime scene kind of approach to our analysis. And so this year, I want to talk about, in keeping with that metaphor, the patient community as informants. And I have to say, it's been the best year I've ever had in my career this last year. So I'm going to start with a question. So I want you to think about this in the back of your mind as I'm speaking. What data do you think we should analyze? And we're going to ask at the end, once you've seen my talk, what data is of interest to you. And I should also mention, I'm a data engineer by training, so I don't do mice or microscopes. So I do computers, and I prepare the data for the brilliant folks on our team and our collaborators, but just wanted to clarify that. I don't really pick which are the best research questions or that kind of thing. My job is like a data librarian, and I get the data together for the folks who want to use it and for all the collaborators who use it through the shared Looker platform and so on. So I just wanted to clarify that. So in 2025, it's been quite a year so far. So as Alan mentioned and Fernando mentioned, we have a year 3 we're in right now for our CDC risk factor study. And my big focus has been the ARC electronic health records data. So we have 127 participants and growing. And we are working on standardizing and harmonizing data with collaborators, which Alan also mentioned, our work with Answer ALS, but also others, which I'm going to touch on. And a big part of this has been sharing ideas with our open real-world evidence communities. And so you might not know that there is a whole community of folks called informaticists or clinical informatics, and their whole focus is not on any specific disease, but on developing best practices for describing people from the electronic health records and other big data sources like claims and such, and how to query those sources. And that is where I have been spending a lot of time in sharing ideas. And we've actually developed a GitHub repository, which is a open source way of sharing documentation on the kind of work that we do. And so there's been a lot of communication back and forth, and it's been fascinating and exciting because every time I come to a community of informatics folks and I tell them I'm working on ALS, they say, count me in, let's do it. Like, let's work in this field. So everybody is really excited to work with us. And very importantly, and something that's been really influential in my view, as you'll see, is our town halls that we had with a group called Her ALS Story. I hope you're listening online, my Her ALS Story friends. And these are young women with ALS. And they shared a lot of their ideas about what they might have been exposed to, conversations that they have with other young women, what might make them different. And we're going to touch on autoimmune disease. So that was a really great question from Dr. Mitchell, because that's what we're going to touch on, and that was what was really of interest to them. So I want to back up a little bit and kind of fill in some of the information that you learned from Alan about how we capture our data and the kind of data that we have. So here you can see our self-reported ARC participant data. So these are the surveys and other forms of data collection that Alan described, like the digital biomarker data and the phlebotomy that's done. And so the way I've laid this out is like, this is your timeline with ALS, and what I'm calling this diagnosed with ALS at 0 months. That's when you first get your diagnosis, and you might not come to the ARC study until, let's say, 6 months. Like, it takes a while to find out about us and be ready to participate in a study. And so then we ask all kinds of great questions, including historical information. So we're asking about your family history, your personal medical history. So we do capture that. But think about how much you can really ask somebody to fill out in a survey, especially somebody with ALS. Like, you have to kind of be a little bit choosy about, the kind of priorities that you're making with these questionnaires, although these questionnaires are really quite extensive. And so then over time, we contribute, participants contribute data at even intervals, and we're so fortunate to have that. But when we have electronic health records, we're able to really supplement and complement the data that we've been capturing with the ARC. And so now you can see at that point where you're diagnosed with ALS, we can see everything that happened at that visit with your neurologist, everything that was collected, all of the labs, all of the tests, all the recommendations, the medications, and so on. So even though we might be collecting some data about your conditions and your early symptoms and such, this might be a slightly more detailed version of that. There might be information that we're getting that you didn't provide to us in the surveys. And then moving forward, even though you haven't enrolled in the ARC study at your 3-month visit, let's say with your neurologist, or even 6 months if you don't enroll in the ARC study by then, when you do enroll and pull in your electronic health records data, we're getting everything from that first visit to wherever you are. And then you can refresh it, and we continue to get that EHR data that supplements and complements what we're collecting in the surveys. But very importantly, and what has been kind of my work and my life's work this last year, has been the years of data that we're getting before your diagnosis. I'm getting sometimes 20,000 documents from people in fairly standardized formats, I was happy, impressed that I could at least decipher a lot of it. So this is called Fast Healthcare Interoperability Resources, or FHIR. So these are formats that are standardized across the electronic health records community, so we kind of know how to go after them and how to decode them once they come in, because we know what we're looking for, but also a lot of notes and a lot of information. And so here I just gave an example. Somebody 10 years ago might have had left arm numbness, and then a few years later, they're having some twitching they're reporting, and then a few years later, they're having surgery on their left side, but maybe they don't get diagnosed with ALS until 2024. And so we're able to pull in and tell these stories, but it's no small feat, as you can imagine, with 10, 20,000 of these documents that are coming into us. And so that's why we've turned to the community for help. So back to the Her ALS story. I made this word cloud as a result of all the conversations that we had with Her ALS story, asking them about their exposures and the things that concern them. And certainly you recognize probably a lot of these words in other areas of ALS research, like environmental and injury, stress and trauma. These are all things that we talk about quite a bit, and we study it with the ARC study as well. But just for this case study, I want to talk about autoimmune disease and inflammation, because this came up a lot, and it struck me that it was so important to them. Now, granted, it's in the news, and there's a lot of great research and papers, but for these young women, this issue was very important. And so I just want to walk you through, how do we take the issues that are important to people in the community and incorporate them into our pipeline in a reproducible way. So it's not just an anecdote, something interesting that somebody told us, hey, have you ever looked at? But how do we now kind of make it a part of our durable pipeline that we can continue to look at and watch for and share with our collaborators? So the first thing we did was we looked at the surveys. So we do ask people if they have comorbidities, in family history, and what are those comorbidities? And we ask about autoimmune diseases like ulcerative colitis, for example. So we have that, and they also have the ability to fill in an open-ended way if they can think of any other conditions that they have. And I'd say, Alan, maybe this is about 10, 20 conditions that we ask about altogether. And so 11% of based on the surveys from the 859 people who completed this in full, 11% have at least one autoimmune condition, based on the list that we asked them and what they filled in the other section. And so a recent US estimate was 4.6%. So there's more people. Is this a statistically significant or scientific finding? Not really. This is just a descriptive analysis, but hey, Her ALS story, this is interesting, right? This is something that they brought up, and let's follow this through. But what I really want to show you is how our open science informatics community is working on this and collaborating as a whole community to help us do better at finding these types of diseases. And so this is an example of a paper from some colleagues from USC and Iowa. And they're kind of disease agnostic. They do this for lots of different diseases, help us in the community identify, and in this case, they were trying to estimate prevalence, but there's lots of uses, as you'll see, for this kind of work. And so they published in an open science way, as a supplement in their paper, they published their code for how they detected, based on clinical guidelines, and really putting a lot of thought into not just the 20 autoimmune diseases, the most popular ones that we might ask about, but like all of them. And so this might be something that you might not even know you have an autoimmune disease, or that this disease that you have or you tested positive for is important. You might not even know that, that's interesting. So when we ask you in the survey, it might not get picked up. But also importantly, when we compare, we want it to be apples and apples. When we say our prevalence of autoimmune, we want it to relate to the paper that had the 4.6%. We want to be looking at the same types of conditions. And so I had adapted their code, thankfully, because they published it. I adapted that, and this is just one step in the process. We have a kind of a long pipeline for going through, but just to give you an example of the way that this is coming up in our work. So I looked at this for all these dozens and dozens of autoimmune diseases, and then you can see, let's see here, the unique participant count. So this gives us a quick glance. At the time that I ran this, there were 15 unique people in this particular section of the EHR database that flagged positive for celiac disease, for example. Oops. I went backwards, not forward. There we go. And then I also flagged, which is blacked out here because it's identifiers, but it also, the code that I wrote also gives us the participant identifiers, and that's important because it allows us to merge the data from the EHR data in with the survey data and the other blood draws and things that we're doing as part of the traditional non-EHR ARC study to help to string all of this together over time. And just importantly, just like people ask me about AI, and everybody wants to know if I'm using AI and such. Well, just one kind of challenge that we have, depending on where we're looking, if it's a structured data or if it's a note, sometimes we get false positives, like celiac disease, because a lot of people, for example, are tested for celiac, right? And so it might initially look like they have celiac, but if you really look in the note, they were tested for it. So there are ways that we try, to tease that out. But this is how that looks to us. And then we go through and process it further and further, and depending on which type of document that we get. This helps us to develop a comprehensive count, and we can look at specific diseases. And then because we have this linkage with the other data and the blood draws that are collected as part of the ARC, I'm able, if a researcher comes to us and says, hey, I'm really interested in celiac disease, who do you have with celiac disease? And I can easily find that and verify it in the electronic health records as well as their self-report. So what does this all have to do with therapy development? This is a question that I get a lot from people in the community. Like, this is interesting to do research on the number of people with this and the number of people with that. It's a curiosity, but what does this really have to do with it? And so I want to give you an example from my own personal life. So I have a child, many of you know this, I have a child named Charlie. Charlie had a catastrophic form of epilepsy, very rare, called infantile spasms. 15 years ago, when he was born and had this disease, there were no known causes for about 90% of people, and that's what they told us about. If you're in this sporadic type of form of infantile spasms, we don't know what caused it, we can't develop precision medicine, we don't know what to do for you. We can try other drugs that might work for other people with known causes, but for you, we don't know. And they would test about, I don't know, maybe a handful, 20 different genes, and look for a couple of other causes, and that was it. But over time, in the infantile spasms community, the parents on Facebook started talking about their kids in terms of these weird symptoms and medical history and phenotypes. I call it Facebook phenotyping. And they would start saying, well, my kid had a stroke and has a vision problem, a stroke in utero with vision problem. And somebody else would say, well, my kid didn't have that, but my kid has autism. And then somebody else would say, my kid has low tone. And so when a new family would come into our community, we would kind of unknowingly, unwittingly, kind of, you go over there with Sheena and you go over there with Beth, right? Like, we would kind of group them together. But then we all started getting our genetic testing done, because we fought for that too. We fought for young folks to be able to get genetic testing whenever there's a diagnosis like that, with industry support. And pretty soon, people are starting to get their cause. Everybody's finding out what their genetic cause is. And sure enough, a lot of those groups that we informally would kind of separate out, sure enough, they represented phenotypes that matched the genetic causes that were found. So a good example of this is COL4A1, a registry that we created on a shoestring with a REDCap database, with an independent IRB, no money, all volunteers. We put that together, and sure enough, and they are starting to look at precision medicine. And this isn't just SCN2A, there's a lot of different communities that have done this. So I know this works, but it has to be done in a very systematic way and a reproducible way. It can't just be anecdotes. It can't just be us talking about it. It has to be us documenting it in a scientifically sound way. So I'm not going to quiz you on this paper later, but I want to show you the kinds of things that we're reading and the kinds of approaches that we're trying to take. And so this is a paper by Dr. Abigail Newbury, and she's in one of my wonderful open science informatics communities, and she gave a talk, if you're familiar with the Observational Medical Outcomes Partnership, she gave a talk to our community a couple weeks ago. And basically what this is saying is, if you put these different data types together in the electronic health record and other data sources, and more than just one domain, so more than just that condition, but maybe labs or other things that are of interest, if you put them together well, you can do better with your genome-wide association studies. So you can basically get more hits and do a better job finding those differences and leading to discoveries. And so, again, I'm a data engineer. I'm not the kind of scientist that decides what's a good research question or what isn't. I don't know, right? But I do know that if there's a scientist who wants to study something and they want good data, I know how to get that for them. And so we're studying all of these different types of methodologies so that we can do a better job with our phenotyping. And a great example of the utility of the EHR data, this is de-identified, obviously, because I can't show you the person's private information or full dates. But this is real data. These are real values that we get out of almost every person who has their EHR data. And this is going over sometimes 10 years or more. And so we're getting all the labs. And the labs are actually really easy to get out. And so we can track all of these labs over time and overlay it with infectious diseases maybe that they had, or hospitalizations, or injuries, or flare-ups of autoimmune, or whatever it happens to be. We're able to organize all of that. And then in addition to that, we're already capturing these lab values with analysis that we're doing as part of the traditional ARC study. So now we have this full record. And the other thing I wanted to mention with labs is I'm also getting, if they have NFL, the important neurofilament light, if people are getting that taken as standard of care or as part of their clinical trials, we're actually able to capture that if it goes into their electronic health record. So we're seeing all of it, and so I'm sure you can see the utility of this. My job is just to analyze, to organize it, but I'm told that this is very valuable. And then finally, as part of my inspiration from the Her ALS story, I remembered that we have this wonderful contact through Tufts, where I used to work, to the Kaiser Permanente Biobank. And so at the Kaiser Permanente Biobank, when you come into their healthcare system, you have the option of participating in a blood draw, surveys, and having your electronic health record data taken, and then you're followed over time, kind of like the ARC study. But it's like all comers, it's everyone who is in their healthcare system. And I found out from them that they have many people who later developed, many meaning maybe a couple hundred, 100 to 200 people who later developed motor neuron disease. But we have their blood from before motor neuron disease. And so one of the things that we're going to look at is the immune and proteomic networks associated with that. And so just as part of this package to complement some of the other things that we're doing, and just to show that the Her ALS story, the things that they said about immune and autoimmune diseases, that mattered, and we put that into our pipeline. So finally, I want to give you an idea of the types of domains that are pretty common, that are relatively easy or getting easier to pull out. Some things are harder, like clinical notes, and I'm happy to talk about that. But But this is just an example of some of the data points and the types of data that we're able to get out. And so I would love to hear from you, and what would you like us to include into our pipeline as we move forward? I mean, as you can see, it doesn't take a lot of effort to write a few lines of code that we can just keep an eye on certain phenomena or data points. So I would love to hear from you.
All right, I think we have time for 2 questions, and I see we have one over there.
Hi, Danielle. Thank you. That was very enlightening. I'm Beth. I work at TDI in the ARC study. We did have a question in the chat about whether there had been ever a link between people that were exposed to like 9/11 and ALS.
Well, again, I'm a humble data engineer, but I do know that, maybe Fernando knows, but I do know that was something that the CDC was studying, right? And I believe that study was shut down, but I don't know what the findings were. Yeah, I don't know, but we can find out and get back to you on that. Yeah. But I do know that was something that was of interest, which makes sense because of the environmental exposures and all the things that the other people in that occupation would be exposed to.
Hi.
Yeah, hi.
I'm wondering if you've looked at people with vitiligo, autoimmune disease, and the prevalence among particularly genetic carriers of the C9 mutation.
So I haven't looked at the prevalence, like calculated that, but that is in our list of what's captured. And we certainly can and pull and have that. So that isn't something that we will continue to have. And so like the way I would envision this working is I capture that, we put it out on Looker along with like the fact that the person has C9 and all of these other things, and then we can all do the research on that together as part of the Looker platform. Yeah. Thank you.